Let me just organize myself a little bit here. All right. Well, everybody, good evening and welcome to our discussion tonight on Hormones 101. I'm Hayley Foster. I'm going to be your host for tonight with my co-host, Dr. Anita Sadaty. I'm thrilled to have all of you here participating in tonight's conversation. As I mentioned in the email you may have received earlier, this is really a conversation between Dr. Sadaty and I. People did send in questions. We will try to address as many of those questions on tonight's conversation as we can. But we ask that you stay muted and keep your microphones closed unless we ask you at the end to open up for discussion. But I feel like we're going to have a really great conversation and there probably won't be time for questions at the end. However, if you do want to ask questions, you could always email me questions and Dr. Sadaty and I will go over them together. I will send them in a follow-up email and who knows, maybe this will become a multi-part series. So again, thank you all for coming. I am Hayley Foster again. I'm 51 and I have 3 teenagers at home. I like to think I'm in the perimenopause stage of my life. Although in our conversation before I turned everybody loose on this Zoom tonight, I was saying that one of the reasons why I started working with Dr. Sadaty was 4 years ago. I decided that I don't want to go through menopause. And so I jumped into hormone replacement pretty early, pre-symptoms. And we're going to get to a lot of the discussion tonight on when is the right time, what should I be doing, how old should I be? And I'm happy to say that we have people on this call tonight that are in their 20s, 30s, 40s, 50s, and 60s, and maybe even above. So we have a really nice range of people here tonight, and we're going to give you as much information as we can to help you on this journey, because it is a journey. So I have the honor tonight of introducing you to Dr. Anita Sadaty. She's a board certified OBGYN and an integrative medicine practitioner. She provides individualized, personalized medical care, focusing on discovering the underlying factors that cause illness, and the symptoms that many of us on this call have probably experienced, are experiencing, or will experience in the future. So, and full disclosure, the information you're going to hear tonight is for educational purposes only, and it is not individual medical advice for anybody on this call. If you do want to work with Dr. Sadaty, we could give you her information at the end and tell you how to do that. And again, this is not a sales pitch to work with Dr. Sadaty. This actually came up as something that I have been asked numerous times by numerous people, a lot of who are on this call tonight, like, I hear you're taking menopause, I hear you're taking hormones, like, aren't you worried about this? Are you worried about that? And so I felt like, why not put this out there as a conversation that other people could take part in? And so here we are. So anything you want to add before we jump in, Dr. Sadaty?
No, I think that it's such a hot topic. It certainly hits a lot of buttons for women at all ages. It's probably one of the most common things that I'm seeing in my office right now because there is more information out there. There's more dialogue, there's more conversation. And so women are really sort of asking the question, is hormone replacement appropriate for me? What does it do for me? What are the upsides? What are the downsides? When should I start? Like, all of these questions are exactly what's coming into my office. So I think it'll be a good discussion.
I think the place where we could start off is talking about the fear behind hormone replacement therapy,
Mhm.
and maybe just give us a quick summary of how do you alleviate some of that fear for people that are coming to you and saying, I'm scared of hormones.
Okay. And that is a big question. Um, I think that we have to put this in the context of the history of why we are in a situation where so many women are fearful of hormone replacement therapy. And I was a young, practicing OBGYN when this started. So in 2002, when the Women's Health Initiative, which was the largest double-blind placebo-controlled trial comparing hormone replacement therapy to placebo in an effort to see whether or not this could reduce cardiovascular disease events. It was over a $1 billion study. What ended up happening was a small subsection of the investigators on this study uh, noted a signal that they thought was concerning for breast cancer in the women who were taking hormone replacement therapy. They then proceeded to write an article that was published in the Journal of the American Medical Association that essentially claimed hormone replacement therapy increases the risk for breast cancer and that women should not consider this as an option for their health. This was plastered all over the media, every magazine, every news agency, every newspaper. Every physician, every woman was struck with fear. Women were pulled off of hormone replacement therapy right away, and it was denied to a lot of women who were really indeed suffering from severe menopausal illness and symptoms. So fast forward, this has been the narrative essentially for the last 20 years. Um, when you look at that study more carefully, what you end up seeing is that, first of all, the risk of breast cancer in the hormone replacement therapy arm was not statistically significant. That alone shuts down any statement that could possibly have been made to say that hormone replacement therapy increases breast cancer risk. Now, the reason that it was so shocking at the time was because there were so many studies. The preponderance of the evidence in the scientific literature pointed to a null effect, most likely on breast cancer risk. As a matter of fact, between 1975 and the year 2000, 83% of studies showed no increased risk of breast cancer. So that study was not, that was out of line with everything else that we had learned about. Let's also look at, so number one, not statistically significant. Right then and there, that study should not have been published. Many of the investigators did not agree with the conclusions of that study, but they were not given an opportunity to even voice their concerns or the reasons why this shouldn't have been published and that the study should not have been stopped prematurely. The second issue is that the women in the study did not represent the typical woman who's going into menopause. The average age of those women was 63. So those women were 10 years out of menopause on average. These were, and on top of that, these were not healthy women. 70% of the women were overweight, 50% of them were smokers, 30% had high blood pressure. So these were not healthy, newly menopausal women. This did not represent what most women looked like when they were looking to potentially use hormone replacement therapy as either a symptom relief strategy or an anti-aging health benefit strategy. So those are two huge issues with the study right then and there. And really, one of the things that we can pull from it is that there is, in fact, a critical window of opportunity of when you can start using hormone replacement therapy to reap the benefits of hormone replacement, such as reducing heart attack and stroke risk, reducing osteoporosis, hip fracture risk, reducing dementia risk, reducing colon cancer. There are a lot of overall health benefits if you start this within 10 years of becoming menopausal. The women who had issues such as increased blood clots or heart attack or stroke were more than 20 years out from menopause in that study. So when you remove those women from the study, there was no increased risk of cardiovascular disease. As a matter of fact, it showed a protective effect. So it's really all in analyzing the data very carefully and looking to see where those signals were present. So it's a mouthful, and I think it's kind of a lot to start the conversation from there. But what I would urge most women to do if they really want to understand this more clearly is to consider reading a book called Estrogen Matters by Dr. Avram Blooming. this book is phenomenal. He's an oncologist, and he lays out all of the data as it was presented over the years. He really dissects the Women's Health Initiative study data in a way that makes it very understandable and also makes it very clear that the conclusions were completely misinformed.
Right. And I want to also just add on to that. There have been 2 articles in the last year and a half from the Wall Street Journal and the New York Times that do talk about the Women's Health Initiative study, and really deconstructing it and laying out a lot of what you just summarized so eloquently. And so if anybody wants to read those articles, they are out there, or you can just, use the Google machine. They really do a great job of breaking it down. So as I said earlier, and I think it's a really great jumping off point, and I think it gives people sort of like that, all right, what is it that I should be focusing on? So what I would love to do really is kind of go backwards a little bit and talk about like what is happening with women as they hit their 30s and 40s and 50s as far as hormones go, just to give us a little bit of background. People aren't really diving in. Menopause is such a hot topic right now and such a buzzword, but a lot of people just are, like, I'm not there yet. I'm not there yet, and don't really want to know what's coming. Or they're just starting to feel the effects and not necessarily, I mean, a lot of people are on this call right now, so people are doing some research and diving in a little bit, but tell us what's happening to our bodies as we hit those key ages of our 30s, our 40s, and our 50s.
So that's a good question. In the 30s, that decade, so the 20s and 30s are when you see sort of the um, largest production of hormones. And the issues that occur in your 20s and 30s isn't related to, let's say, deficiency of hormonal production. That's what starts to happen in your 40s and your 50s and beyond. But what you can start to see is imbalances in hormones. So women in their 30s, if they have hormonal imbalance, are going to have very sort of prototypical symptoms that we think about, like PMS symptoms, breast tenderness, bloating, moodiness, anxiety, fatigue, headache, heavy periods, prolonged periods, bleeding between periods. Like these are all symptoms of hormonal imbalance or dysregulation. In that particular decade, let's say in your 30s, that's when a lot of lifestyle influences are at play. So whether you're having irregular periods or regular periods and symptoms, that is an imbalance in your hormones, but that doesn't mean that your ovary doesn't know how to produce hormones adequately. That has more to do with how your body is responding to hormones, how your body is processing hormones, and how your body is eliminating and detoxifying hormones. So if you have issues in any 3 of those steps, there could be production issues, there could be metabolism issues, there could be elimination issues, then you're going to have symptoms of hormonal imbalance. So that's where lifestyle factors are really critical. Stress, sleep, nutrition, exercise, all other inflammatory disorders that can happen at that time. Those and certainly gut disorders are imbalanced. So all of that heavily influences how your hormones are going to express. In your 40s, you have kind of both issues. You have deficiency issues, but you also have imbalance issues. So your hormones start to decline in your 40s, but it may be that your estrogen levels are still out of balance to your progesterone. So progesterone tends to be the hormone that we start to miss a little bit more. That, because the eggs are getting a little older, the quality of your ovulation changes and your progesterone production changes. So many symptoms, I mean, it could be all over the board. You can certainly have estrogen deficiency, but most of the time we see what we call estrogen dominant symptoms, where there's not enough progesterone to balance the estrogen that you're producing. And therefore, you can get symptoms of heavy periods, faucet-like bleeding when you get a period, lots of cramping, prolonged bleeding, PMS, headaches, like all those other symptoms. However, you can also be in the deficient side where you're now starting to get hot flashes, night sweats before your period, or you're starting to experience some vaginal dryness or painful intercourse because the vagina is very sensitive to declines in estrogen. You can start finding like loss of libido or more difficulty with orgasm. So those are symptoms that happen potentially late 30s and early 40s. Once you start moving into the 50s, that's when the decline of both hormones is pretty significant for some. I mean, I still have patients that are, 57, 58 and having regular periods to their chagrin. But I tell them, listen, you're gonna miss your hormones when they go. So enjoy. But they are experiencing typically more deficiency syndromes, more hot flashes, more night sweats, more anxiety, palpitations. You wake up with chest palpitations, heart palpitations, vaginal dryness, painful intercourse. Depression is big. So a lot of women in their 40s and 50s who are suffering from depression, it really is often related to hormonal imbalance and estrogen deficiency or testosterone deficiency. All of those, and progesterone as well. Low progesterone is highly associated with anxiety and panic. So I used to, in my older practice when I was younger, I remember all of these women in their 40s and early 50s going to the emergency room thinking they had a heart attack. But really, what they were having was progesterone deficiency mediated palpitations and anxiety and panic. So, they would get the $1 million workup for EKGs and echocardiogram and cardiac enzymes to look for heart attack. And really, what they needed was progesterone. So that's sort of what's happening in each of those decades.
And that's, I don't want to start talking about how so many doctors are just not aware of diagnosing those symptoms. And, we're fortunate to have somebody like you who is on the functional medicine side, on the OB side as well, or the gynecological side, who has that information and is able to, diagnose in a different way than a lot of traditional OBGYN practitioners who, a lot of times, and I will just relate this to myself, is that, I was on birth control for a million years, and then I was on an IUD for, another 10 years after I had children. And at no point during any of that was my, and I loved my gynecologist, but at no point was she talking to me about what any of this could be doing to my hormones.
Mhm.
And so, some people that may be on this call in their 20s, 30s, even women I know are in their 50s and 60s are put back on birth control. Can you touch on that a little bit? Because I think
Yeah,
that there's
I would love to talk about that. So, and this is from somebody who was a huge prescriber of oral contraceptives for the majority of my career. Um, I really don't think that there's enough discussion about what the downsides of oral contraception is. Unfortunately, you know, the doctors that are supposed to be the experts in hormone, like gynecology or endocrinologists, they're the first ones to just rush to put you on a birth control pill, regardless of what your problem is. It doesn't matter not getting your period, getting it too often, too heavy, too light, too crampy, PMS, headache, whatever. It's used as a panacea to deal with any hormonal issue, endometriosis, fibroids, ovarian cysts, like ruptured cysts, like anything you speak about, it's a birth control pill. And then what happens is that it's certainly very convenient, but you're basically ignoring what's happening under the hood because the birth control pill is shutting down your own endocrine communication system. And your hormone, like I like to call the period the fifth vital sign. So if your period is not normal and you're suffering or there are issues around your cycle, that is telling you there's something not right with your health. So to then just slap on a birth control pill um, to shut off the symptom, it's like putting tape over the check engine light when it shows up. It's like, let's just cover that up and I'm not going to look at that. Okay. That's not helpful. So here we are, women going years and years and years and years on a pill to then stop it because they want to try to get pregnant or stop it in their 50s to find out they have all kinds of issues going on that were essentially ignored. There's no search for why it is that you're experiencing these hormonal imbalance issues. So that's one of the biggest reasons that I really have concerns about using birth control pills because they are there forever. Women don't use them for a few months, they're using them for decades. And women are using them as hormone replacement. So in your 50s, if you start experiencing hot flashes or night sweats, but you're still having a period, you're put on a birth control pill because there's this false sense that somehow that's safer than being on low doses of bioidentical hormone replacement. Birth control pills are high doses of foreign hormones. So, how that is considered better than putting you on hormones that your body makes, which is what you would use if you're doing hormone replacement therapy, um, at low doses to fix the imbalance is beyond me. Like, why that's a safe option in your 50s, and even as you said, even into your 60s, makes no sense to me. It's because the narrative of how horrible hormone replacement therapy is has really clouded the judgment of physicians. Like, they're just completely afraid of it, but they have no problem putting on somebody on massive doses of hormones like you find in a birth control pill.
And not just a narrative, it's a false narrative that
Right,
we're
right.
learning, right? It's not
It
even a
is
real
false.
narrative.
It is false. And so there's 2 parts to it. A, it's the covering up your symptom, not and just ignoring. But the second part is you're not looking for why there's the problem, and that problem will affect your health eventually.
And it
So
will eventually pop up somewhere else.
it's gonna pop up. You just so those are my biggest concerns. There also is a situation, there are some women who, when they go on birth control pills, because of the effect of the birth control pills on the liver in terms of increasing sex hormone binding globulin, which does sort of sequester all of your hormones, including testosterone. A lot of women have low libido and vaginal dryness on a birth control pill and painful intercourse. And in some cases, it's not reversible, even when you stop the pill. And that's certainly not something that people are saying. Fortunately, for most women, it is reversible. If you stop the pill within 3 to 6 months, those symptoms should resolve. But in some, it doesn't. The sex hormone binding globulin elevation will stay elevated, and it's tricky to try to get that back down.
Mhm.
So,
Can you talk briefly? I think there's a lot of confusion between a synthetic hormone and a bioidentical hormone.
mm, yeah. So, um, a lot of people think that when you're talking about a bioidentical hormone replacement, that you're talking about something that comes from a yam or some naturally derived plant source. It's not something you can get from a regular pharmacy. It has to be compounded. It has to be made by specialty formulas. None of that has anything to do with bioidentical. Bioidentical basically just means that the hormone that you're taking is the exact same chemical structure as what your ovary formerly made. So if it's bioidentical estrogen, it would be estradiol or estriol or estrone. Those are the 3 estrogens your body makes. If it's progesterone, it's progesterone. It's not medroxyprogesterone, it's not norethindrone, it's not any of these weird words. It's progesterone, same structure. And testosterone is, again, testosterone. It's not a patentable mutated form of a hormone. That was also another interesting aspect of the Women's Health Initiative, is that the hormones that were used were not bioidentical. They were Premarin, which is extracted from pregnant horses' urine. So Premarin, pregnant mare's urine. And Provera, which was known to cause cancer in animals. So that wasn't the best choice. But even though that's what they used, the estrogen only arm in the Women's Health Initiative showed actually a decreased risk of breast cancer. So even though the Premarin is bioidentical to a horse and not a woman, it was still pretty good. So that's all that bioidentical means. You can get those in many forms. You can get them as oral pills, you can get them as creams, you can get them as patches, you can get them as vaginal inserts, capsules. There can be pellets that are injected under the skin. Um, you can get many of these from your regular retail pharmacy. Does not have to be compounded. All it means is that the structure is the same as what your ovary produced. That's what bioidentical means.
Thank you for that. And then in terms of, is there a price difference, or is it insurance dependent on bioidentical hormones from a compound pharmacy? Is there a reason to go to a compound pharmacy versus a regular pharmacy?
There are good reasons to use compounding. So number one, if the form or the dosing that's available at a retail pharmacy doesn't work for you,
Mhm.
and you need to get a dose that is very personalized to you because you're not finding the balance with what's available, then you would want to compound. If a form of the hormone is not available that you need, for example, most progesterone is used as an oral pill, micronized progesterone, but it's available in two doses, 100 milligrams and 200 milligrams, both of which, in my opinion, are a little high to start with. So if you needed 50 milligrams, then you need to compound it. Or if you need a progesterone cream, then you need to compound it. Testosterone, there is no option at a regular pharmacy for women. So that has to be compounded. For sure, compounding is more expensive. If you have insurance that will cover bioidentical hormone replacement from your pharmacy, it's usually going to be more economical. Compounding means that they are literally making this stuff from scratch for you, so it's more time consuming. There's more effort. The ingredients have to be purchased for you. It has to be made in a special way. So there's cost to that. Whether or not your insurance covers it, I think is very insurance dependent. I mean, as you know, insurance wants to cover nothing. So they would probably say no. But that's not, that's neither here nor there. If you need it in a special way, then you kind of have to bite the bullet. But for the most part, I would say 80, 80 to 85% of women can get away with what's available at a regular pharmacy.
Okay, thank you. Something you touched on earlier, and I want to come back to it, was almost the consequences of not taking hormones if
Mhm.
you are a woman. And you and I had a conversation about women fearing this one thing that can affect them, which is breast cancer, right? Women fear breast cancer. And your comment was, we're not walking around as a giant boob. There's all these other parts of our bodies we should be worried about, not just our boobs, right? So there's brain function, there's heart function, there's kidney function, there's skin function. And so can you talk a little bit about what you see as the consequences of not taking hormones
Mhm.
as a supplement?
And that should be how the discussion is couched, right? That there are risks to not taking hormone replacement therapy, just like there may be some risks to you in terms of taking it. Um, and we can jump into that. So, regarding women who cannot take hormone replacement therapy or should not take it, in an ideal world, the medical community would allow a woman to make their own decision about it. But there's a lot of paternalism in medicine, and you're told that you can or you can't. Even if you've done the research and you've made the decision that this is the best health option for you, that may not be blessed by your physician. So, but The only reason that you really can't go on hormone replacement therapy is if you had an active cancer that is estrogen motivated, such as a breast cancer or a uterine cancer. If you're actively dealing with that, being treated for that, then most likely it's not necessarily a great idea to go on something that could promote it. It doesn't cause it, but it could promote it. If you have unexplained vaginal bleeding, like bleeding that's not, if you're in the menopause, it's sort of never considered normal. If you're perimenopausal, if you're having erratic, strange, um, unregulated bleeding, you have to figure out what that's from, because otherwise it could be a uterine cancer until proven otherwise, which also can be stimulated by estrogen. So those are two big no-nos. The other one could be if you had some hormonally mediated blood clot. However, in my opinion, um, women who have had blood clots are typically on some sort of medication to prevent blood clots, and therefore going on hormone replacement therapy would not override your medication. And if you take estrogen through the skin, it does not increase your rate of blood clot factors from forming. So I don't even really think that is a contraindication. What are the downsides to not taking it? So on average, women live 3 years longer when they're taking hormone replacement therapy. They have up for between a 30 to 50% decreased risk of any kind of heart attack event or cardiovascular event. And just to put that into perspective, 40,000 women a year may die from breast cancer, but 250,000 women a year die from heart disease. So if you're talking about what
Can you
is
just say
like,
that number again? Because it really
sure.
is mind blowing.
So 40,000 women a year may die from breast cancer. 250,000 women a year die from heart disease. So if you're going to die from something, it's most likely heart disease. And I read a statistic that women over the age of 65 with a diagnosis of breast cancer most likely will die from heart disease, not breast cancer. So like we talked about, we're not like one big walking boob. Like we have brains, we have bones, we have muscles, we have vaginas, we have hearts, we have all kinds of systems in our body that require or do better, function better with hormones. Um, the other thing that we want to look at is dementia. So if you were to use hormone replacement therapy for at least 10 years, your rate of dementia would drop. So there's a 30% decreased risk of developing dementia if you were to use hormone replacement therapy for at least 10 years. You also need to use it prior to being 10 years out from menopause. If you started hormone replacement therapy 10 years after menopause, you may not get the benefit, or you may even increase the risk of dementia. So that's why there's this critical time frame where getting on board with hormone replacement therapy reaps more benefits for patients. We also see decreased osteoporosis and hip fracture risk, which, in my opinion, if a woman has osteoporosis, hormone replacement therapy is probably the best treatment for that. A lot of the other alternative therapies for osteoporosis have a lot of risk, a lot of downside. The benefits are short lived. Some don't protect you from hip fracture. Some medications actually build very unstable bone where you may be at risk for odd torsing fractures. A lot of these medications put you at increased risk for cancer. I mean, I don't prescribe those medications. Like I can't. I'll send somebody to an endocrinologist if they want a medication like that. But so if we have heart disease protection, brain protection, osteoporosis, hip fracture risk protection, decreased risk of colon cancer, improved urogenital symptoms. So incontinence, how about that? Not peeing all over yourself. That's kind of nice. We have more enjoyable sex, less painful sex, better orgasms, skin. So in general, There is reduced skin aging because hormone replacement therapy can maintain collagen and elastin levels. Um, you have a decreased risk of autoimmune disease. So there's definitely evidence that women on hormone replacement therapy can, who let's say have MS, have less symptomatology and less progression. So, certainly aches and pains, like joint aches and pains go skyrocketing for women in menopause, and they don't even know why it's happening. They don't understand why all of a sudden they're diagnosed with fibromyalgia, and it's because they don't have estrogen and progesterone on board. So there are so many health benefits outside of not having hot flashes and night sweats. So,
A couple of things that you and I talked about also that I want to address tonight are, you mentioned this earlier, are the lifestyle changes,
mhm,
right? So as we start entering our 30s, 40s, 50s, 60s, 70s,
mhm,
all the way up, from somebody who wants to, make it into the hundreds. There's lifestyle changes that you could be making in order to, reduce some of those symptoms that you may be experiencing from menopause. Do you want to touch on what some of those are? I mean, I could share, some of the things that I've done for myself, and I'm sure I'll get a lot of boos on this one. And when you and I first met, I was very into my wine and
right,
selling wine, and I was a wine pusher. And over a year and a half ago stopped doing that, and with that saw the elimination really of no night sweats, no heart palpitations, and I was having those symptoms on nights when I was drinking,
yeah,
and not even drinking that much, and I was drinking clean wine, but I was still getting some of those symptoms.
yeah.
um I mean, I'll let you jump in. I know, food, exercise, but I'll let you talk a little bit more about what those lifestyle changes are.
Well, I think you hit the nail on the head of a big one. There is this sort of strange um, dichotomy between what your body wants and how it reacts to when it gets what it wants. So, for whatever reason, in the 40s and 50s, women they crave wine, and not even just alcohol, but wine in particular. And yet, that is so detrimental to health in general, and women get really angry that they sort of feel like they hit their late 40s and 50s and, like, they cannot drink anything, and it's annoying, because they really enjoy the wine, but then they suffer. They wake up in the middle of the night sweating, their sleep is completely disrupted, they get a headache, like, you basically become very intolerant to it. So it's a trigger in particular because wine is both high in sugar and it's a liver toxin. And so your liver at night is trying to, it sort of has an opportunity in the middle of the night to start cleaning up the body. So it starts to eliminate toxins, deal with pollutants, get rid of hormones that need to be processed out of the body, deal with some of the prescription medications that you're taking. Like it's the time for it to really clean up the body. You then add in at night a toxin and a sugar. Those are two things now that the liver has to manage. So instead of doing cleanup for the day, it now has to dissemble this new toxin that you're bringing in, and it has to manage the sugar load. And both of those things create an inflammatory response, and it also will create an adrenaline response. So, in line with that, so any kind of blood sugar dysregulation is going to cause hot flashes and night sweats. So, I know women that, they say they eat well, they're exercising, they're doing all the right things, and they're suffering from hot flashes and night sweats and anxiety and panic and all this other stuff. So once you get rid of the alcohol, once you get rid of caffeine, once you stop snacking throughout the day and grazing on like little carby things, eat a lot of protein and just stick with like three well balanced meals a day, aiming for about 30 grams of protein per meal, lots of vegetables, and less processed food, you will not have hot flashes and night sweats. They will go away because when you are eating carby things throughout the day or snacking throughout the day, you're actually trying to manage low blood sugar episodes. You just don't know it. And then when you go to bed, here you are expecting to not eat for 7 hours straight. Not going to happen. So your body is used to you snacking and eating all day long. And then when you go to bed, your blood sugar drops. You don't have something to snack on. So you get a hot flash and a night sweat as a result of adrenaline coming up. And that's what wakes you up. So I can get rid of people's hot flashes and night sweats without hormone replacement. I mean, you just have to balance your blood sugar, eat a lot more protein, not snack, stop the wine, stop the caffeine, and you're done. You don't have any of that anymore.
Right. And I think that's really hard for a lot of people, right? It's doing those things those are, you just listed 4 major lifestyle changes for people. That's
What we
not
live
easy. And I
for.
will say one of the biggest things that helped me was wearing a continuous glucose monitor, because you literally have the data and you can see the spike like in the moment, like
Mhm.
literally in the moment you can see it. And the interesting thing is, and this is where the anomaly was, that when you drink alcohol, whether it's wine or tequila, I saw the question of tequila in the comments. Does tequila count? When you're drinking at night, your blood sugar will actually decrease from the alcohol, right? As you're drinking it, you'll see the dip in your blood sugar. But what happens afterwards is this spike in the middle of the night.
Mhm.
And it's not just your blood sugar spiking, you get the heart palpitations and all that stuff too. But I will say a CGM was really just such an eye-opening experience for me in terms of all of those things. On days where I was just eating 3 meals a day, I wasn't see or 2 meals a day because I was doing time restricted eating. I would see very different results on my CGM. And so, I mean, that could be like a whole nother conversation about, you know, blood sugar management and how even just getting a hold of your blood sugar and managing that can help you with many of the symptoms of menopause as well.
Yeah, I mean, that's essentially the first thing that I do with most of my functional medicine patients is I try to get them moving it towards an anti-inflammatory diet, but more importantly is to eat in a sugar balanced way. And so many symptoms. I mean, that and honestly, what most people don't realize is so much of anxiety and insomnia, which are really top symptoms for it's really related to caffeine intake. And I was like, "Yeah, but I only have 1 or 2 cups by 11 AM." It doesn't matter. It takes 24 hours to break that down. And as soon as they stop that, the anxiety and the sleep disturbance go away. So it's tough. Like, we're ingrained with so much of this habit, these sort of not great habits that we have. But when you get rid of them, they make massive changes in your life. I mean, fatigue changes, mood changes, headaches change, energy drops in the afternoon. All that goes away when your blood sugar is more stable, for sure.
Mhm. I will say the coffee is the one thing I have not given up yet, but I don't feel like I need to, right? So I'm not having symptoms. I'm not having sleepless nights. So, just because someone says, don't have coffee, and there are coffee alternatives. I've tried, mushroom coffee, everyday dose, and most of them that are out there. I've settled on everyday dose, but I will add that to my coffee. But if you're not having, sleep issues, it
Correct.
doesn't mean you have to give up your coffee. If you're
Correct.
having sleep issues and you're having headaches and you're having hot
Correct.
flashes, then there
Yeah,
might be a reason for you to give it up.
100%. And that's what I say. I tell patients if you have anxiety or sleep disruption, you must get rid of caffeine and alcohol to see, at least see whether or not that's the trigger. Give
Mhm.
it 2 to 3 weeks and see. If it doesn't affect you, it doesn't affect you. If you don't have anxiety, you don't have sleep problems, then you're fine. Like you
Right.
have no issues with that. But if you
Right.
do, you need to consider it.
Right. So one of the questions that came up in the chat was, and I don't know if you know the answer to this, but are there different things being taught now for traditional medicine doctors in terms of educating them more on female reproduction and hormones and menopause, given that, I think we said before, 1 billion women will be in menopause by 2025.
Mhm.
Um, Working with younger doctors, do you know if any of this is getting through to these medical schools where doctors are getting a different education now, or is it still the same textbooks?
Yeah. Well, I wish I knew the answer to that. Since I'm not really working in the hospital anymore, I don't come in contact with the medical students or the residents to see, what their training is like. Um, from what I can tell, however, when patients come to me after they've seen another gynecologist or practitioner um, who is young, it doesn't sound well, let me just give you an example. I had a patient who I hadn't seen in a couple years. She doesn't live close by anymore, so she was seeing another gynecologist. She had been on hormone replacement for a number of years. I think she was 60. She saw this new younger gynecologist who said, you really need to get off of that hormone replacement therapy. And the patient was like, well, I've been on this for years. I feel really good on this. Why would I need to get on it? She goes, well, it increases your risk of breast cancer. You really need to get off. And the patient was like, well, I would prefer to not get off. She goes, well, I'm going to write you for a lower dose. She said, okay. I mean, I need a prescription. So if that's what you're willing to give me, I'll take it. She came back to my office basically practically crippled. She had diffuse body pains all over. She couldn't sleep well. Her brain fog was massive. 2 o'clock hit. She had to have a nap. She was like, I don't understand why I'm feeling this way. I said, because you're not on the right amount of hormone. Like you're not. And she didn't let her take her testosterone. I mean, so if that's any indication of what the younger
Okay.
generation is looking, it's not looking good,
Right.
so but I can't, I don't know what medical schools are doing. I will say that when I was last in the hospitals, which was 7 years ago, the medical students were very pharmaceutically driven. They were very big into medicating everything with a medication. Um, Not hormones, but they loved antidepressants. They loved anxiolytics. Pain medication. Like basically they would treat, Ambien, like
Every symptom.
every symptom had a
Right.
different medication. So, the medical schools are unfortunate, they're funded by pharmaceuticals. So that's how they're taught.
Right.
So I'm not sure. I mean, I hope it is changing because patients and customers, if you want to look at a patient as a customer, they're demanding it.
Mhm.
They don't want that. They want something better. So,
I think this is a good segue into testing, right? So again, depending on what your age is, like what are some of the initial tests that you recommend people do in order to figure out if, aside from having symptoms, if hormone replacement therapy is right for them and how much hormone replacement therapy or which hormones are right for them?
mhm. The gold standard really for most patients would be in any age, 30s, 40s, 50s, 60s. The gold standard is to do serum testing. So that's blood testing. The thing is that you have to have knowledge about the timing of blood work. If you have a woman who is still having her period, when is it that you want to try to test her? And ideally, it depends on what information you're looking for. If you're looking to see that her estrogen, progesterone levels, her peak levels are ideal, then you want to test her about 1 week before she's about to get the first day of her period. That will tell you what her peak hormone level is. If you're talking about someone in their 40s, if they're having regular periods, same thing. But you may also want to check her pituitary hormones, her FSH, LH levels to see if they're starting to rise, because that coincides with the ovary becoming less sensitive to the request from your brain to make hormones. In your 50s, I So I don't think that I don't necessarily use blood work to decide if someone needs hormone replacement or not. Because you have women who stop getting their periods for a year or two and they're not symptomatic, but they want the longevity benefits. I have women in their 40s who are still getting periods, but are having severe estrogen deficiency symptoms. And if the blood work doesn't reflect that, I'm not going to withhold medication for her. So I use it as a way of, number one, trying to get a little bit of a sense of where someone might be, understanding that every day is different. Like one day you can be having hot flashes and night sweats, and another day you can have breast tenderness and water retention because you just ovulated. So, it varies literally from day to day if you're still menstruating. If you're menopausal, which means that you've had no period for a year in the right age group, which is usually over 45, then by definition, your estrogen, progesterone, they're going to be low. There's almost no point in testing that because they're low. I mean, they're menopause. You're not making that anymore. But I do like to test testosterone and DHEA, which is an adrenal hormone that helps to support women when they become menopausal. So DHEA is called sort of the anti-aging longevity hormone. It's from the adrenal because it will turn into estrogen and testosterone and all these other things. But the important thing with serum is knowing when you're testing it at different times of the cycle. And for menopause, you want to be able to test all the hormones. And then I also like to see what the hormones do once we put women on hormone replacement to make sure that their levels are adequate enough to get the bone protection, the heart protection, the brain protection, and things like that. There are other tests like the Dutch test, which is very popular. That's the dried urine test for cortisol and hormones. So that tests your adrenal hormones, as well as your sex steroids, estrogen, testosterone, and progesterone, as well as all of the breakdown products. So if patients were willing to pay for that test, because it costs about $350, it's not covered by insurance. But what I love about that test is if you are on hormone replacement therapy, you can monitor to see how you're breaking down your hormones and make sure that you're breaking them down in safe pathways. So there are certain breakdown products of estrogen that can be a little more toxic to DNA, and there are others that are safer and more benign. So in the Dutch test, it gives you like a pie chart of how much is the toxic one, how much is the safe one, how much is the intermediate one. And there are certain percentages that you want to aim for. And so if I see that, I can manipulate that to make sure that women are breaking down their hormones in a very safe manner. That's not, to be honest, typical. I don't typically run that test because most women are not willing to pay for a test like that. So, you just do the best you can, and that's it.
But okay, so I've taken that test numerous times. How often do you recommend people take that test a year? Like every
So it
6
depends
months?
on what the findings are. So let's say that someone's adrenal hormones are messed up and you want to try to fix them and you're into implementing some strategies to try to rebalance the adrenal hormones. Or let's say that on the Dutch test, you do have a higher percentage of the more toxic metabolites of estrogen, the 4-hydroxy estrogen metabolites. Then I would institute some intervention to try to change that. And then I would want to check that again, let's say 3 to 4 months later. Adrenals don't change quickly. So if I have somebody on an adrenal program, then I would want to test them maybe like in about 6 months. It's not going to change more quickly than that. If patients are on adrenal protocols, and they're stable, but they continue to need them, then we could test them once a year. Hormonally, if once they are in a more safe range, I don't necessarily need to test them again, but you could keep an eye on that once a year, once it's stabilized and normal.
Mhm. And so just I mean, I'm an open book, so I really don't care about sharing. One of the things I did prior to going on hormones was I started taking a DHEA. I was taking a DIM supplement. So I started a supplement regimen prior to taking hormones.
Mhm.
And so is that something, I guess, depending on people, is there, and I don't know if you're comfortable just throwing out like, yeah, people should be taking a DHEA.
Mhm.
But is there something that people can do that are really uncomfortable still with taking a hormone?
So, I definitely used to do a lot of adrenal programs to treat, hormone-related symptoms, and it can be very successful, actually, but essentially what you're doing, though, is you're just giving hormones that are upstream in the biochemical process, and they're being converted into estrogen and progesterone. So, like, it's sort of a little bit of a backdoor to trying to restore some hormones for patients, but there's no question that if your stress hormones are out of balance, it's going to create a lot of hormonal symptoms. So if you can get somebody's adrenal stress hormones into balance in their 30s or 40s, even their 50s, if that is one of the root causes of hormonal symptomatology, then it will correct it. The adrenals are one source of hormone imbalance. Intestinal issues are a big source. Inflammation and toxins are another source. Um, Food sensitivities and food intolerances are a source. So, all of those things can end up causing hormone symptoms. So, if you correct all of those imbalances, the hormones will rebalance and you'll feel better. So, you can absolutely correct menopausal symptoms or hormone symptoms with adrenal balancing if the adrenal is what's wrong, if that's what's wrong with you.
Mhm. I know it's 8:30, or it's actually after 8:30. I have a million more questions I could throw your way. But for the sake of time and your time, and I truly appreciate you giving us all your time tonight. This has been amazing. Um, just drop it in the chat if this is something that you would be interested in continuing to sort of sit in on, or participate in. It's definitely something that Dr. Sadati and I have talked through. We've even talked through putting together a program on balancing hormones, where you would be given a prescription to go get a hormone test, and then we would talk through different, like what the testing numbers look like. So we are interested to get your feedback on tonight's conversation. um, I think as a just a great way to wrap this up, is is there I would say my piece of advice to anybody that's on this call tonight that is interested in learning more about their hormones and figuring out like how to start feeling better, because I just want everybody on this call to know you don't need to feel like shit. It doesn't matter what age you are. We should all be feeling good. And so if hormones is the answer, or lifestyle changes are the answer, or the issues, there are answers. Um, and there are some natural ways to do that. So I guess if there's something that you want to leave everybody with, Dr. Sadati, what would that be?
Um, I think that the main idea behind this talk, in my mind, was just to allow women to understand that they really should have very open conversations with their practitioners about the symptoms that they are experiencing, about what the options are for treatment, and also if the practitioner is not open to what your thoughts are, what your research has been, what you've been educating yourself about, or they don't have other ideas beyond what has already been suggested, that you try to find somebody who at least considers themselves a specialist in hormonal treatment, or a menopause physician or menopause doctor. Because if someone at least acknowledges that they have expertise in that area, you may be more likely to get a more nuanced and broad approach to treating your symptoms. Um, but it starts with just even questioning or even handing your doctor some information or studies or a book or whatever, that you think has been very enlightening and helpful, and that may demonstrate a way that you want out of your hormone situation. So you have to advocate for yourself. You have to educate yourself. You have to find a practitioner that will be a partner with you. Um, and and certainly people like Hayley, who are working around the clock to bring this amazing information to all of you guys and to our community, is like a wealth of information and an amazing resource. And she's really done it and seen it all. And so really sort of communing with people like-minded like that. So just don't give up. Like, don't think that, what you're getting is the end of the line. It's really not. You just have to find your right tribe.
Mhm. And then I was going to add to exactly what you just said, which is you have to be your own advocate. And if your doctor that you're currently going to is not giving you a really good reason why you shouldn't be taking hormones, then maybe it's time to find another doctor.
Yeah, yeah. I mean, I hope it is turning around. I think it is. I think it is, but um, not soon enough. Like, it's not fast enough. So we have to kind of light a fire under people's, offices to get them to understand that there's a need, and that there are other ways to think about managing hormones and women's health. So
Right. Well, thank you very much. We have a lot
thank
of
you,
thank yous in the
Haley.
comments. Thank you. This has been wonderful, eye-opening, and loved seeing everybody on here tonight. So thank you,
Thanks for
everybody,
everybody
for
coming.
joining, and stay tuned. More to come.